So we'll go ahead and start off here where we left off before. So I think the last case we looked at was this case where we saw a lot of bone edema here. But what you notice here is that the subtalar joint is abnormally configured in the middle facet. Instead of being horizontal like is normal, it's obliqued, and therefore the force transfers through the subtalar joint space are abnormal, and we're getting these trabecular bone injuries, which can be painful. And there are a lot of little anomalies like this that it can occur in the ankle area. I don't think it's really, well, maybe it's possible, but I'm not sure they've all been exactly categorized. But you just have to look at it. When you see a lot of edema and so forth, then you have to try to figure out what the mechanism is and look at the anatomy. And if it's an abnormal anatomy, then that may be a congenital reason for the problem, especially in younger individuals. So, okay, let's see. Ashu, what's going? This patient had lateral ankle pain.
Hi, John. Dr. Jakutis?
Hi.
Okay. We're all here. All right, so lateral ankle pain. Having some trouble looking for anything that's abnormal. Is that just the retinaculum, or?
At this point, I would just say that this is the distal end of the peroneus brevis muscle at this point. But now it seems like it's going in a little bit too far at this particular point. And if we look at the sagittal images, there's kind of an extra structure down here in this location. And this is actually extension of the peroneus brevis down into the actual tunnel in the lateral aspect. And we've seen this rare problem in other cases. You can see it in the rotator cuff sometimes, but if the muscle extends down into a confined tunnel that's really made for the tendon, it can sometimes cause trauma to the muscle and symptoms. So this is an abnormal extension of the peroneus brevis muscle.
Congenital variant.
Right.
Also, John, is the calcaneus on a right angle, or is it just the way it's
It's positioned.
positioned?
Yeah, it's just the way it's positioned in the skin.
Okay.
Quite sure. It looks like this patient may have a small Haglund deformity. There's some edema and some fluid in the retrocalcaneal bursa. So I'm not sure if that's a partial thickness tear of the distal Achilles or this is a variant. There's an extra muscle there. This is an accessory soleus muscle.
This is actually just a low-lying soleus, where the soleus muscle comes all the way down into this area. And then there's an extra muscle here between kind of the low-lying soleus and the perineal muscles here. And this is one you'll see fairly frequently. So we have low-lying soleus, and this is the peroneus cordis muscle. There are 4 different varieties, which we'll talk about. I don't try to remember them. But this is a separate muscle, kind of rarely seen, and this is where they have palpated a mass, where it has a separate tendon that comes down and attaches to the lateral aspect of the calcaneus in this location back here, and occasionally it can present as a mass. In the sagittal images, here you see this extra muscle coming down with a tendon attaching to the calcaneus here, and this is a peroneus cordis muscle. And if you look for it, you'll find it. Most of these people just don't notice them. And you can get a similar kind of muscle on the medial side here as well, in that kind of same location. And this one's called an accessory soleus on this side. And then here's a typical example.
Is that common, John? It's not very common as far as I know.
No, it's not common, but sometimes it can present as a mass. and not be misinterpreted by the radiologist if they're not familiar with that anomaly. Here's a more typical appearance of the peroneus cordis. This is the peroneal retinaculum back here. Here are the peroneal tendons, and we have an extra muscle coming down in this location. And on the coronal images, we can see it coming down through here and attaching to the lateral aspect of the calcaneus. And here's that extra muscle. So on the lateral side, it's called a peroneus cordis. If you have a similar kind of thing coming down on the medial side, it's considered an accessory soleus.
Now, is that why the MRI was taken, or is it because of pain of some kind?
No, this was just an incidental finding.
That's what I figured. But the plantar aspect of the calcaneus, is that normal?
Down here?
Yeah.
Yeah, it's a
that could be painful.
little bit irregular. No, that's probably not entirely normal. Right in here. Could be. Okay.
Okay, so the red arrow is pointing to
This patient had
lateral ankle pain. Is that? I'd like to see that on the sagittals and the axial. Okay, so there's actually within the lateral aspect there is an accessory. Pronator cordis muscle. But I don't anteriorly. Is that normal appearance of the fibula, or it seems like we're too far down. I don't know if that's okay.
It just doesn't look like a normal tendon.
No.
See when you follow it down here, there's a lot of signal.
Mm-hmm. It's really okay. And this is a torn. Okay. Torn.
So these accessory muscles and tendons can also be a cause of symptoms, and there are really a bunch of others that have been described. Here's an article in Radiographics which describes a number of different times. Here's the peroneus cordis. It says, and I think they describe 4 different types of peroneus cordis. And then you can have a flexor digitorum accessory, longest coming down along the course of the flexor digitorum, which we can see right in through here. In there. Yeah, I'm not going to spend too much time on this. And then there's an internus, which can come down. I think that the bottom line is you can get accessories here. Most of these are not important, and I've generally not found them to be a significant issue. But the thing is to remember is that it's not uncommon to have accessory muscles and tendons down around the ankle area. And if you see something that's unusual, especially if it looks like it may be causing symptoms, then you might need to look it up and figure out which of these different accessory tendons and muscles it might be.
If you don't look for them, you won't find them.
Yeah, that's probably true too. But here we can see coming down through here. All right. And then anteriorly, you can have the same sort of things anteriorly. This is the extensor hallucis and extensor digitorum. And what we're seeing here is that the muscles are extending much farther down than normal. Where we normally should be tendon, we're getting muscle coming down along the tendons. There's the anterior retinaculum in this location, which makes it a confined space, and so you can occasionally get symptoms because of the congenital anomaly where the muscles extend down into the extensor retinacular area, producing ischemic changes in that area as well.
All right, so this is a 3-year-old female with prominent medial aspect of the foot since 3 months old. And there is some soft tissue prominence there on the radiographs. The bones look all right. And then we have some ultrasound images, I think, of the medial foot, as well as an MRI. Yes. Medial muscles. So hypertrophy of the medial muscles.
It's also quite rare of congenital hypertrophy of the plantar muscles, which can present with deformities here.
Are these both feet?
My understanding is that they're generally both feet.
I have 4 images. Are they the same foot? They don't look like it.
These are bilateral feet. So this one was bilateral. Here's another one which was unilateral.
6-year-old girl with foot mass here. We can see hypertrophy of all of the plantar muscles. And it, oh wow, yeah, it's pretty extensive.
And then there's kind of a list of the different names for different foot deformities. Kind of a general term, past acquired deformities of the foot. Valgus, obviously lateral deviation. Varus, medial deviation. Equinus is fixed plantar flexion of the hind foot. Calcaneus is fixed dorsiflexion of the hind foot. Cavus is a big, large longitudinal arch. Planus is a flattened arch. You're familiar with those two. Adduction is displacement toward the midline, and displacement and abduction is the opposite. John, do you want to make any comments on these?
Well, they can all be treated in one way or another. Usually it's osteotomies for the bony deformities, and osteotomies, in other words, cutting them bones and fusing them in one way or the other at different angles. You have to be a pretty good carpenter at some of these. That's basically it. In terms of other problems, sometimes just tendon transfers and using screws and
Okay.
staples, etc. So it's every condition has one or two procedures. What I found interesting in the new camels is that the procedures for the feet have the multiple procedures for various conditions have pretty much disappeared, and they're picking one or two procedures that are used in most cases.
Okay.
I found that very a very good finding.
Good. They must have data that they work.
That's right. Like the Jones procedure has been replaced with a similar procedure as the Jones, but with a little extra twist to it. And I will talk about it, I guess, when we get there.
Yeah.
But it's interesting. Only one procedure for instability.
Okay. Good. All right. Let's see who's next.
This is a 25-year-old female with chronic foot pain. Looks like there's an exaggerated longitudinal arch here. I would say some pes cavus here.
So, John, this is one that you don't like. What's the problem with the cavus deformity?
Like this one, for instance, you do a wedge osteotomy, take out the bone with the base anteriorly, and then put it back together in a straight line. Okay. And it's taken care of. Now, do they all work? Well, yeah, not necessarily, obviously.
Okay. Yep.
But they can be fixed.
Good. Okay, and some of these are associated with other congenital syndromes. All right, well, this is kind of the end of our introductory lecture. So I'm going to quit and let's come back in and we'll start the next series. Okay?